You all want to listen in. Okay. Hello, everyone.
Hello.
Welcome to Ask the Doctor. Actually, in this case, it's several doctors. I'm Diana Gonzalez, and I'm your moderator for tonight's event. I'm the Media Relations Director for Sylvester Comprehensive Cancer Center. And this afternoon, we're coming to you live from Sylvester at Deerfield Beach, also known as the Papcore campus. And we're here to talk to you in depth about breast cancer. It's October, Breast Cancer Awareness Month. And we want to thank Susan G. Komen, Florida, which is live streaming this program on Facebook. And we're going to be taking some questions from you after we hear from our panelists. A lot of you are here, and we also have viewers on Facebook. So please keep your questions brief. Let me introduce the panelists. First of all, to my right is Dr. Monica Yepes. She's Chief of Breast Imaging and Director of Breast Imaging Services at Sylvester. Dr. Charles Vogel is the Director of the Women's Center here at Sylvester at Deerfield Beach. He is a renowned breast medical oncologist and breast cancer researcher. Dr. Laura Freedman is a radiation oncologist who specializes in breast cancer. Dr. Christina Pozo-Kaderman is a psychologist and is here to talk to us about cancer support services at Sylvester. I skipped over Lesley Klein. Sorry about that, Lesley. Lesley is a clinical oncology dietitian and the clinical nutrition manager for Sylvester, and we'll discuss how what we eat might affect our cancer risk. And last but not least is Dr. Avisar. He's a surgeon and he's busy seeing patients. So when he's done, he's going to join us as well, right next to Dr. Pozo-Kaderman. So thank you all for being here and taking time from your busy schedules. This is a very important topic. And these experts serve patients in a variety of ways at Sylvester. And this summer, Sylvester became South Florida's only NCI-designated cancer center, as you can see from all the logos back here. Many of you might not know exactly what that special recognition means to patients and to the South Florida area. And so Dr. Vogel, he's going to start us off because he started his career at the National Cancer Institute. So if you could just briefly talk to us about the significance of this designation.
Well, basically, this is a very prestigious award. It's now the 71st of the comprehensive cancer centers around the country, and the only one in South Florida. The other one in Florida is the Moffitt Cancer Center in Tampa. Sylvester is South Florida's leader in patient-focused cancer research. And that's what most of us at this table do in their own specialties. The NCI designation will expand our ability to do research and our ability to provide patients with greater access to novel therapies, personalized medicine, which we're very active with, probably the most sophisticated of the clinical trials available nationally and internationally, and helps with collaboration with other comprehensive cancer centers. The NCI designation means we've been recognized on a national level by the NCI and by our peers for our outstanding work conducting research in our laboratories, mostly downtown, treating patients in our clinics like Deerfield and Plantation and Coral Springs, Kendall, Lennar, Hollywood. We have satellite centers in a number of places. And reaching out to underserved communities with innovative preventive strategies.
Mm-hmm.
So these are the things that are going to be facilitated by this very large grant from the National Cancer Institute, as well as being part of a very select group of cancer centers nationally.
Thank you, Dr. Vogel. And now each one of the panelists is going to talk about the specific area that they specialize in. Dr. Yepes?
Okay, so is my mic working? Do you hear me?
I hear you.
Right there? There's better?
Yes.
Okay. All right. So as a breast radiologist, my job is pretty much twofold. The first is to try to help you decide what the best screening approach for you is, because screening for breast cancer varies depending upon your risk factors and your type of breast tissue. So that's something that we do. And once we do that screening mammogram, the goal is to try to find small cancers before you feel them, because we do know that early detection is extremely important and helps determine your probability of survival. Okay, so early detection increases survival rates. So that's the first thing. And the second thing, if we do find a breast cancer, we as radiologists help the other clinicians at this table determine the extent of the disease, meaning do you have a small cancer, just one, or are there several sites that have cancer? Has it spread to the lymph nodes, to the skin, to the muscle, to other areas? Because all of these factors will help these other specialists determine what your treatment will be, whether you can have a small surgery, whether you need a larger surgery, whether you should have chemotherapy before you have surgery, and whether you should have radiation and how much radiation you should have. So all these are the things that we do, and hopefully trying to perform very minimally invasive procedures to get to that diagnosis, needle biopsies, guided by the different modalities that we use in breast imaging, which are mammography, ultrasound, and MRI. So that, in a nutshell, is what we do in breast radiology.
I'm a medical oncologist, and a lot of patients come to us and get confused because there are medical oncologists, there are radiation oncologists like Laura Freedman next to me, there are surgical oncologists like Dr. Avisar, who will, I'm sure, at some point join us this evening. So each of us has our own specialties, and medical oncology deals with drug therapy. To many of you, drug therapy means chemotherapy, and we're moving farther and farther away from chemotherapy as the mainstay of treatment for many cancers, and we're trying to move in that direction more and more in breast cancer as well. So what are our modalities in medical oncology? In breast cancer, the mainstay of treatment for 70% of women with breast cancer is anti-hormonal therapy. So people automatically think of medical oncologists as chemotherapists. But really, if anything, we're hormonalists. And we use a lot of anti-hormonal therapy and use it as long as we can in order to help to minimize the toxicity of some of our other therapies. After hormonal therapy, chemotherapy, we call it cytotoxic chemotherapy. Cytotoxic means cell-killing chemotherapy. And we have many different forms of chemotherapy. So we probably have about 10, 12 different active drugs, which certainly help in 2 or 3 different ways. We can use them before surgery to shrink tumors down. And our goal there often is to completely eradicate the tumor, where when the surgeon goes in, all tumor is gone. And that's our goal with what's called neoadjuvant chemotherapy. We use chemotherapy after surgery, that's adjuvant chemotherapy, in order to improve the likelihood of cure. Because of some of the advances in medical genetics, we're now using less chemotherapy than more chemotherapy, more hormonal therapy, less chemotherapy, because of a couple of tests like Oncotype and Mammoprint, which help predict who needs aggressive therapy and who doesn't. And finally, well, not finally, because I forgot one other modality, we have precision medicine. And one of my patients today is getting her second type of precision medicine. The first precision medicine study, she had very far advanced disease, responded beautifully to immunotherapy, which is our fourth modality. So we have immunotherapy and we have targeted therapy as means of precision medicine. That is, we can test for the genes in a patient's individual tumor, find out the genes, hopefully, that are driving that tumor. And then we do have drugs that can be targeted specifically for those specific genetic targets. So we have anti-hormonal therapy, we have chemotherapy, we have so-called targeted therapy, and we have immunotherapy. And that's what I deal with.
Okay. I work with radiation. My name is Dr. Laura Freedman. I run the department down here in Deerfield. I only have one modality, it's radiation, but I have different types of radiation and different methods to set up the radiation and different opportunities to manipulate the radiation to provide every patient with the best treatment plan for them. Over the last several years, the innovations in radiation have been methods to target the disease and minimize dose to the nearby normal structures. So for patients with left-sided breast cancer, we're always very concerned about treating the heart, which we don't want to treat. The heart is not a target when we're treating breast cancer. It's an avoidance structure. So by having patients hold their breath with what we call deep inspiration breath hold, we're able to separate the heart and the lungs from the breast, thereby minimizing toxicity and late complications. We can also place patients on their stomach. And by placing patients on their stomach, the breast falls down and away from the body. And that can also not only minimize dose to the heart and lungs, but also provide a better treatment plan for patients who are larger breasted. And the breast will then set up in a much more reproducible manner. We have some fancy treatment planning that we can use called intensity modulated radiation therapy, where we can individually target certain areas and use complex treatment planning to really what we call dose paint and deliver dose specifically to different areas, different amounts per day to different areas that require different dosing. And one of the new innovative types of radiation that's coming to Sylvester Comprehensive Cancer Center at our main site in Miami are protons. And protons are radiation, it's all radiation, but we have the opportunity to deliver the dose in a different manner where we could come straight at a tumor on the left side, but actually stop the radiation right at the heart. So we're able to really designate where the dose goes in those areas, again, minimizing dose to where we don't want it to go. And I wanted to just compliment on other comments that Dr. Vogel made when he said that he uses his neoadjuvant chemotherapy prior to the surgery that Dr. Avisar will do. We now have patients who come through after surgery with no disease. And there are opportunities going forward where we might be able to determine through the studies that are being done here at the Cancer Center on all of our sites and locations, looking at certain patients who have had a complete response to their cancer and enrolling them in a trial to determine if they still need the radiation or do they no longer need it. And what a great find it would be for me to have less patients, for patients to no longer require radiation after having had a mastectomy and having a complete response to their treatment. That would be amazing to me, to have less patients that need radiation, less patients to potentially develop a complication. So trials like that one that are being done, and trials looking at shorter courses of radiation and smaller fields for radiation, just targeting a tumor bed, are wonderful opportunities for the patients that we can offer here as well.
Good evening. I'm Lesley Klein. I'm a clinical registered dietitian, and my team and I are we're very busy debunking a lot of myths that a lot of our patients come in after finding information on the internet. So while we try to agree as much as we can, we do try to explain why things may not be the way you may see it on the internet. we work at a university. It has to be evidence-based. And so I always tell my patients, if your body is the garden and cancer is the weed, I leave it to the experts who have the science behind them to get rid of that weed. As a dietitian, I want to help nourish the garden so the weed has a really hard time to grow back. And so what we find is that not only can nutrition help to reduce your risk of recurrence of the cancer, but it can also help to guide you through the journey while you're getting your treatment. And we can help manage some of your side effects through your diet. And so that's pretty much what we do. Especially with breast cancer, we know that that's one type of cancer that most patients will wind up gaining weight versus losing weight. And a lot of times women are very surprised that, well, if I had to have cancer, at least I could lose a little bit of weight. Breast cancer tends to gain. And we know that postmenopausal breast cancer has been linked to obesity. There's actually 12 cancers that are linked to obesity. So in survivorship, we do a lot of weight management and different modalities of how we can address that, because it's not one size fits all. And we understand that everybody is individual, and some people may want to try intermittent fasting. Some may just want to do calorie restriction. And we find that some of those things may actually help during your treatment as well. There's research out now looking at some of those modalities to help you control your weight while you're going through the treatment, and also managing the treatment better as well.
Hi, thank you so much for having me. I wear several different hats. So one of the things that I do administratively is oversee cancer support services. And this is something that makes Sylvester very unique, because we recognize that when you get diagnosed with cancer, it's happening not to just a body, it's happening to a total human being, and it affects your entire family. So our goal is to provide all the services that you may need to help you get through that cancer diagnosis, treatment, and even during survivorship. And so administratively, one of my goals has been to develop all those services. And so I'm going to list some of them just so you have an idea of what Sylvester offers. And most of them are offered for free of charge for our cancer patients, which again makes us very different. So obviously nutrition is part of what we offer, because again, that's a very important tool as part of what you may need, throughout your treatment and recovery. We offer psychological and psychiatric services. And so by training, I'm a clinical psychologist. So that part I not only oversee administratively, but also offer those services. People often ask, well, I'm not crazy. Why do I have to see a psychiatrist or a psychologist? So we often have a lot of resistance for people wanting to come see us. And part of that is because there's this idea that you only see a mental health professional if something is really wrong. And what I say here is that often the difficult part is the process that you're going through. So we're not seeing you because there's something wrong with you. We're seeing you because there's something wrong with what you're having to go through. It's very challenging. It's different. You may not have had the skills to cope with it. And that's what we're there for, to help you develop and find the skills that you may have used in the past to help you get through things. We also offer exercise physiology, and everybody that we have as part of our team is trained specifically to work with patients going through cancer treatment. And again, more and more we know that the role of exercise is so helpful, not only during treatment, but also part of your survivorship. And we know every time that you open a magazine, you read about it. Exercise helps prevent so many things, right? So many health situations. So we offer that. We also offer massage. So any of you who come here to get your treatment here at the Cancer Center knows that we have a massage therapist who's with you during the time you're getting your chemotherapy. So that makes us pretty unique, again, specialized in working with cancer. So they're not going to offer any type of massage that could possibly hurt you. We also offer yoga. And I think many of you who come here know we offer it twice a week. Trying to think, we have a chaplaincy program as well. We have a music therapist. we have arts and medicine, and I think some of you have been able to attend some of our programs here. So again, the recognition is that everybody doesn't cope the same way. So not everybody's going to want to go and talk to a psychologist or a psychiatrist to cope, but maybe the way you cope is by finding another mode of expression, such as art or music, and that's why we offer those services. So just important to know that as a comprehensive cancer center, we do offer all of that. The services that we do charge for are acupuncture and, again, psychiatry and psychology, but we work with the insurance. And then the last thing that I do is I'm a certified sex therapist, and I work on sexual concerns during and after treatment. And it's an area that's very sort of not recognized. Rarely does somebody, when they get diagnosed with cancer or at any point, even at the end of treatment, get asked about changes in their sexual life. And we know that treatment will affect your sexual life. And I think it's important to recognize that and to talk about it, because otherwise I think patients and their partners are sort of left in the dark. Is this normal? Is it going to be this way all the time? So we offer different programs for your sexual health as well.
Okay, so I'm Dr. Avisar. I'm a surgical oncologist, a breast surgeon, and if I have to tell you what breast surgery is about in 2019, it's actually counterintuitive. It is all about doing less than doing more. If 50 years ago or more, the treatment was pretty much radical, remove everything, cut everything, stop doing, try to save life. We are now going to the other direction, figuring out what we can do better without damaging the quality of life, but also without damaging the treatment of cancer. So what we find ourselves doing, starting from the beginning, is counseling women about prevention and following a bunch of patients with high risk, what we call, and figuring out how we can prevent development of cancer and who does and who does not need a prophylactic mastectomy. We find ourselves more often than not telling patients, now you don't need a bilateral prophylactic mastectomy than the other way around. Sometimes we do recommend, but it's not that everybody needs a bilateral prophylactic mastectomy. When it comes to patients diagnosed with cancer, that's also the same thing. Do everybody need a complete mastectomy? Well, the goal now is to remove the cancer and offering the alternatives and options so that someone can make an informed decision whether really one wants to remove the whole breast or one maybe wants to save the breast. Does one need to remove both breasts or maybe only one? And if one wants to remove part of the breast, we can do this in a cosmetic fashion, keeping a symmetrical appearance and something that patient will be happy with in terms of the appearance, in terms of the symmetry with the other breast. Many times we have women now who are happier about the look of the breasts after they've had a lumpectomy with a combined breast reduction and lift than they had than before. So it's like a kind of a secondary gain. So not only we remove the cancer, but now we have insurance pay for a lift and a reduction, and everything looks good. So that is what the goal of breast surgery seems to be evolving into. Sometimes we do that in combination with our colleagues from medical oncology to shrink the tumor first. And all those options are things that were not available before. When it comes to radiation as well, knowing what is the effect of radiation is going to be on the breast and trying of planning so that there are not going to be deformities from the radiation. So if Dr. Freedman told you about who does not need radiation because it's been a complete response, we also know that some patients may not need radiation because of a certain age. And sometimes we can limit the radiation to part of the breast and something that is pretty cool that we've started doing now also at the University of Miami and Sylvester Cancer Center is sometimes being able to select patients, not all of them, to give them a radiation in the surgery itself, intraoperative radiation at the time of surgery. And that way, a patient does not have to come back for many treatments. But more than that is that there is no damage to the skin from the radiation. So really the external appearance is very nice. The other main thing we concentrate in is all the aspect of the lymph nodes. As you probably know, when one has breast cancer, there is a need to address the possible spread to the lymph nodes. And in that aspect as well, we've been doing less than more. So if 20, 30 years ago, every patient would have had her lymph nodes removed, we now know that many times lymph nodes do not need to be all of them removed, but we can only remove sometimes 2 or 3 lymph nodes, and those may not be affected, therefore sparing the rest of the lymph nodes. Sometimes, even if a lymph node is affected with breast cancer, we are able, again, with combination of chemotherapy or other treatments before, we can, what we call downstage, we can call those lymph nodes to become not cancerous after treatment, and then again, save the patient from having all the lymph nodes removed. We know now more than before that removing all the lymph nodes is what is most bothersome to the patients on the long range, because that not only affects the appearance of the body, but also affects function. It affects the function of the arm. It can cause swelling of the arm. And so we try not to remove the lymph nodes if it's not necessary. In those cases that the lymph nodes are positive, as I said before, we try to turn them into negative lymph nodes, so meaning kill the cancer cells in the lymph nodes by medications before surgery. And sometimes we reverse the order of surgery and systemic treatment just because of that, just in order to try to kill the cancer in the lymph nodes so that we don't have to remove the lymph nodes. In those patients who still have to have those lymph nodes removed, we have also been able to develop some cool techniques to try to prevent and reconstruct lymphedema and reconstruct some of the lymph node function and more the drainage of the lymphatics from the arm, and being able to reconstruct some of this drainage and minimize the risk of lymphedema. Lymphedema in general is something that is not only bothersome to the patient, but is expensive to the medical treatment in general, expensive to society. It's loss of days of work, inability to work, a lot of treatments, chronic lymphedema therapy, pumps, sleeves, and so on and so forth. And that happens if we do an abdominal dissection in 15 up to 20% of patients into certain extents. But when we don't have to remove the lymph nodes, it's much less likely to happen, more in the range of 5%. And if we have to remove the lymph nodes and we can do some reconstructive, preventive approaches to those lymphatic channels, we have been able to decrease that risk to also in the range of 5%. So all of those things are pretty much brand new to the field over the last couple of years. And we are fortunate to be here where people come from all over the world to learn how to do this from us.
Thank you, Dr. Avisar. Appreciate it. Well, we'd like to open the floor to any questions. I saw some people copiously taking notes. Yes.
I'm 76. I was told, I moved down here 3.5 years ago. I had my last mammogram in New Jersey, and I was told I don't need one. Do I? Don't I?
Well, actually, I wanted to ask Dr. Yepes about that myself, because I think there's a lot of confusion out there about when to have a mammogram, when to start having them, how often you should have them. So, Dr. Yepes.
So that's an excellent question, and we get asked that a lot. So if you heard all the hubbub about screening, mammography, and many of the guidelines, there's a lot of controversy, and that was one of the controversial issues. So when you look at breast cancer screening, we're looking at preventing mortality or reducing mortality from diagnosing an early breast cancer. So of course, age is important, but not all 74, 75-year-olds are the same. So the older studies performed in the 90s, when they looked at the benefit from screening, they just didn't have enough of a patient population in the older than 74 group to definitively say we can benefit or not benefit from it. And that's why they said, we don't have enough information. They didn't actually say you should not be doing it, is that we don't know if there's a benefit from doing it. So many studies performed after that have shown that patients over the age of 74 who have an early diagnosis have better quality of life than the patients who wait until they have a larger palpable mass. So again, as you've heard over and over, if we diagnose things earlier, then we have less surgery, less probability of needing chemotherapy, of needing radiation therapy, of having to deal with the lymph nodes, et cetera. So when we get asked that question, we have to look at everything. How healthy is that 74 or 75-year-old and older, right? So not all of them are the same. If there are very important other medical conditions, then maybe you should not be doing mammography, but a very healthy 74 or 75-year-old who may have a 20-year life expectancy should be having her mammogram, because we're going to improve the quality of life of that person. So a couple of questions. First, sometimes I get an 85-year-old who looks very healthy, and I tell her, I see something that we need to deal with. And she says, well, even if it is cancer, I don't want to deal with it. So the first question is, would you do something if we found something? So that's the very first question. And then after that, are you healthy enough to be treated if we do find something? Because some patients may not be healthy enough. And then the third is, what is your life expectancy based on how you are, what your family history is, et cetera, et cetera. So it's not a simple yes or no question. We have to take a lot of things into consideration, and it's something that you need to think about and discuss with your primary care physician.
Thank you
Does
so
that
much,
answer the
Dr.
question?
Yepes. Go ahead, yes.
About 2 years ago, I was in a horrific car accident, and because of the seatbelt and the airbag, I had started getting a lot of lumps in my breast right under here. And I've had biopsies, I have ultrasounds, sonograms, contrast mammographies. And so in the 2 years, I've had a lot of, and now my doctor said maybe the next time maybe an MRI, just because she just wants to make sure. But there's a lot that are still here, and some they said are oil cysts, and that will never go away.
So unfortunately, scarring from trauma and car accidents are one of the most common causes. They can be very confusing when we look at a mammogram, because scarring can look like cancer. So even though you do have that history of having had that car accident, sometimes it becomes a little concerning when we look at the images. So we need to follow until that scarring kind of resolves and organizes itself. And then we can kind of move on. But there is a period.
It will eventually be less.
It may not disappear, but it will stabilize in a way where whoever looks at your imaging can say this is definitely just scarring. It's just that until it gets to that point, it may be confusing and may require some additional workup. But eventually it should stabilize, and you should be able to move on to your routine imaging.
Thank you.
Thank you, Dr. Yepes. Josh from Susan G. Komen. No, we were wondering if there were any Facebook questions. Not yet. So we'll stick with the folks here. Thank you very much. Go ahead.
This is for Dr. Avisar. I'm wondering what the latest school of thought is with invasive ductal carcinoma in one breast and LCIS in the other breast, actually in both breasts, in terms of lumpectomy and radiation versus bilateral mastectomy.
So there are really two different pathologies here. The one of them is the LCIS, which we believe is a little bit of a misnomer. We prefer to call it intralobular neoplasia, which is a proliferative change or proliferative tendency of the lobules of the breast. You mean that those lobules of the breast are at risk of developing breast cancer. That risk, as you said correctly, is a risk which applies to both breasts and is a lifetime risk. So what we can do to decrease that risk is one thing. And there are many things that can be done to decrease that risk. So if, again, years ago, the only option was to remove both breasts or do nothing, there is now much more options. And we do have a whole a range of medications we can give to patients, which are preventative and specifically for intralobular neoplasia have been shown to be extremely effective in preventing up to a decrease in 80% in the lifetime risk of breast cancer. The second thing is the invasive ductal carcinoma you speak about, which is a true cancer which has developed in that specific patient, which could or may or may not be a result of the intralobular neoplasia. So then the question is, does this patient who has cancer on one breast need to have removal of the other breast to prevent another cancer? But that is also not something that can be just answered just like that. It depends on a lot of additional things, what is happening in the other breast, whether we believe that this cancer has developed as part of the intralobular neoplasia or not. Generally speaking, cancer on one breast is not a significant risk to the cancer on the other breast. We used to think that it is really jumping or related one breast to the other. The studies have shown now that in the most cases, the risk for the other breast is much less than we used to think. I specifically don't give percentages because it's very difficult to calculate the risk for the other breast. There's so many factors, what's called multifactorial, family history, body mass, diabetes, a lot of other factors, radiation to one breast and so on and so forth. But generally speaking, we talk about the risk, which is much less than we thought, more of a one-digit percentage over the next 5 or 10 years. So it's really not a very high risk. But when somebody presents with both things together, then again, a discussion has to be entertained with the patient whether or not it would be worthwhile to remove both breasts. Again, as I said, most of the times that would not necessarily be the recommendation, and we would recommend to treat the cancer and to continue with a preventative approach to the intralobular neoplasia.
Thank you. Yes.
I guess I wanted to bring up BRCA for people. I'm a long-term survivor, and I'm 32 years. And at the time, there was no BRCA testing, but there is now. Also the parent of 2 daughters who are BRCA positive, and in the last 2 years, they have had the prophylactic mastectomies because of continuing cystic problems. I just wondered, as far as future monitoring, I was seeing an oncologist yearly when I lived in New York, but I haven't. I've only been going to a gynecologist. I'm going to be 70 years old, so, you know, I'm very, very fortunate. But I just wondered what you recommend for monitoring for younger women who are BRCA, and as well as for myself. Is there anything special that should be done?
Dr. Vogel?
Well, BRCA is a big problem. It depends on whether you have breasts at this point, whether you have ovaries at this point. And we do have patients who are, family members of my patients, just as your daughters were tested, have got to make hard decisions as to whether or not they're going to do preventive surgeries or not. Most women who are BRCA carriers will opt, depending on their age, to have their ovaries removed for a couple of reasons. Number one, removal, ovarian cancer is more deadly than breast cancer, more difficult to find at an early stage. And that's one reason to remove the ovaries. The second is that removal of the ovaries is a way of reducing the risk of the development of breast cancer. And I don't know if many people realize that. So removal of the ovaries is something, if the patient has, if the individual, they may not be a patient because they may not have cancer. They're just a BRCA carrier. But if they have had their families and are not planning to become pregnant, then it's a good idea to have the ovaries removed. Whether one elects to have the breast removed is a very emotionally charged subject for many women, especially younger women. And it is possible through close surveillance, and by close surveillance, I really mean MRIs. MRI is the most important way that we follow BRCA carriers. And I do have a number of women in my practice who have elected not to have bilateral mastectomies. I would say that the majority not the majority, a large percentage of patients, of women who are BRCA carriers don't want that hanging over their heads, knowing that there's an 86% chance of developing breast cancer in their lifetime. And therefore they opt for bilateral mastectomies. But we do have women who do not, and they are followed very, very closely, probably twice a year, once a year with MRIs. And with early diagnosis, they should do well.
Thank you, Dr. Vogel.
Speaking of the women who still have their breasts, so once they're diagnosed as being as a mutation carrier or any first-degree relative of someone who is known to have a mutation should be treated as such unless they get tested and find that they're negative. And so recommendation is to begin screening no later than age 30, some even earlier as much as age 25, depending upon how early the cancer presents in that family. So for example, if the mother who's a carrier was diagnosed at 35, then maybe that daughter should start at 25. And so with annual mammograms and MRIs. And there's recent evidence suggesting that instead of just having a routine mammogram, that the mammogram might be a mammogram with contrast. So for example, if the patient is having her MRIs in January, in June, she should have a mammogram with or without contrast. And there's new evidence, new as recent as over the last 6 months, showing that maybe contrast-enhanced mammography might be a better solution for those patients. And just to mention that we are doing contrast-enhanced mammography on main campus. We started it on main campus and will eventually be spreading it out to the other satellites as well. So just to add to that.
My daughter was 15 when she had her first cyst.
Thank you for sharing, and thank you, Dr. Yepes. And we have a question from one of our Facebook viewers. Josh?
Meditation, besides meditation, what else can be done to help improve neuropathy caused by chemotherapy?
Dr. Pozo-Kaderman.
Well, I think that for that, we do have some various options. One of the things that we're doing now, and we're planning to do it as part of a study, is to start looking at massage as a treatment for neuropathy. And so there are some studies that seem to suggest with some neuropathies that massage can be very beneficial. And we know clinically that several of our patients that have been seen here and have worked with our massage therapists have found that helpful. So that's one thing. Then, believe it or not, some of the medications, and again, this would be to talk about with your medical oncologist, but some of the medications that are anti-seizure medications can actually be beneficial and could help with neuropathy. And there are some types of the antidepressants that also can be helpful. But for people who want to stick with something that's less invasive in terms of, having to take something orally that may have other side effects, massage and then acupuncture. We have had some of our patients who go through acupuncture and have found it extremely helpful.
One thing to add, I know with diabetic neuropathy, sometimes patients L-glutamine and alpha-lipoic acid. It may not help with chemotherapy-induced neuropathy, but it is something that diabetics will sometimes take.
And in medical oncology, we do recommend alpha-lipoic acid, L-glutamine, and vitamin B6 as sort of a neuropathy cocktail And then, of course, we have other drugs that we use, such as gabapentin and Lyrica, sometimes Cymbalta. These are drugs that are used that can sometimes help to ease the discomfort of neuropathy.
Thank you. Yes.
This has to do with screening. I was 38 when I got breast cancer, and my children at 28 had to do their mammograms and ultrasounds. One of them is 31, one is 33. The 31-year-old, this year, they decided just to do the ultrasound first. If they didn't see anything, not to do the mammogram. Is that, I didn't insist that she have one. Is that acceptable?
Well, I mean, there might be a decision to try to minimize radiation, but the rule is 10 years prior to the diagnosis in first degree relative, the youngest first degree relative. So,
Well, she did have an MRI last year.
oh, okay, so she's
this
having
year- that was
MRIs.
part of last
She's
year.
having
This year they
MRIs.
Yes, and this year they decided just to, they were gonna do both, but they said, oh, let me just do the ultrasound first and see if that looks okay. And they said it was fine, and she didn't need the mammogram.
But she's having an annual MRI.
No, that was her first MRI. She was having an annual mammogram and ultrasound.
I would
This year-
suggest that she have a mammogram.
Okay. Thank you.
Thank you. I have a quick question for Dr. Freedman. What percentage of breast cancer patients need external radiation, and when is it recommended?
So it's difficult, as stated earlier, to give any percentages because everything depends on the individual circumstances. But in general, for patients who have a lumpectomy, they're typically going to be recommended to undergo radiation because the studies have shown that while a mastectomy is not necessarily required for patients who have an early stage breast cancer, mastectomy versus lumpectomy in those patients, the survival is identical and the mastectomy is no longer needed. That when we look at those patients, the subset of patients who had the lumpectomy, adding radiation after the lumpectomy decreases the chances of the breast cancer returning and improves overall survival. So standard of care following a lumpectomy would be to add radiation. That being said, we're aiming to do less, as Dr. Avisar pointed out. And so there are circumstances where we team up and we can have the intraoperative radiation, and that can be done right at the time of surgery, one-stop shopping in Miami. And then there are opportunities where we're looking to see whether or not patients will benefit from the radiation in comparison to the risks. Specifically, there have been studies looking at women over the age of 70 with small tumors that are hormone receptive, and they're going to be taking hormonal therapy with their medical oncologist. And in looking at those women, there's an opportunity for observation after a lumpectomy as long as they're going to be taking their hormonal therapy. It's always a conversation, and it's a conversation regarding the risks and the benefits of the radiation. So if I have a 71-year-old woman whose mother is still alive at 97 and she works full-time, plays tennis, and goes out every weekend, she may choose to have the radiation because there is still a risk reduction, a significant risk reduction. But what we are pleased to know is that at about 10 years, the risk for any of those patients is likely to be less than 10% recurrence. It will drop down to probably about 2% with radiation. But you have to take into consideration. So if I have a woman who comes through that's 78, has some other challenges with her health, maybe it's really not necessary to bring her in for the radiation. What's nice additionally is that we've shortened the courses of radiation. So we can either do a 1-week course in certain patients or a 3-week course in other patients post-lumpectomy. So it's really much easier to get radiation these days. But again, it's a conversation. What's really nice too is that we're now working with the specifics of the breast tumor, which has been something that has been unique more towards the medical oncology side, looking at whether or not if you take the piece of the tumor and send it for certain molecular evaluations, whether or not there's a benefit to the chemotherapy, and then making a determination to help avoid chemotherapy in women. We're now doing that for some of the breast cancer patients. specifically for DCIS, which is the pre-cancer, sort of the stage 0 leading into an invasive cancer that's not invasive. There's actually a profiling study that can be done, 2 different ones, on the tumor to determine in a ductal carcinoma in situ patient how beneficial radiation will be and whether or not they will still need the radiation or benefit from it. So we're looking at opportunities going forward to minimize radiation. Stated, even for some of our more advanced patients who have a mastectomy and lymph nodes positive, there are studies being done looking to see that if those patients who seemingly would always benefit from radiation in the past, if they will still benefit from radiation in the future. And I'm pleased that we have patients enrolling in this trial here so that we can answer this question going forward and potentially minimize radiation for certain patients.
Thank you, Dr. Freedman. Oh, yes. Oh, let's start with you.
In 2011, I had a lumpectomy, and then they decided to do, at the time, I thought it was a new treatment where you go for the radiation twice a day, where they inject it. And they, as was mentioned, they said it was too close to the heart. They didn't want to do it, so I went for the regular radiation protocol. And then for 5 years, I took an anastrozole. Now I'm not on anything, so is that the 2% chance that it could come back, or?
Yeah, so it sounds like what you're describing is that you had they were looking at partial breast irradiation. So those are some of the shorter courses. And just recently at our national meetings, there were some studies that came out comparing partial breast irradiation, which is only typically recommended for a smaller tumor that's very localized without significant spread to the lymph nodes. And you just treat the tumor bed, there's a margin around it. The tumor bed is always the most likely spot for the cancer to recur. So by focusing on highly selected patients with a local area, treating just the tumor bed, there were protocols that did it twice a day for 1 week only. There are 10 treatments twice a day.
No, 2 weeks with twice a day. But
Okay.
then they only did 3 treatments because they said it was too close to the heart.
Yeah, the one that was in the protocol where they did it very focal was twice a day for 1 week. So 10 treatments, but over 1 week. And there are different ways to do that. You can direct the radiation just very focally, external beam. There's also where you work with the surgeon and they place a catheter or a balloon style catheter directly into the tumor bed at the time of surgery. And then patients have a catheter that's in place, but we actually insert a radioactive source directly into the catheter, directly into the tumor bed. And what's nice about that is that it's very focal. It's called brachytherapy. It simply delivers the high dose radiation to that tumor bed, and it can really spare the skin. Being just the tumor bed and over a shorter time period, which has been a really nice. Therapy after the lumpectomy and radiation, after the local therapy, but we would certainly like to hope that the risk of recurrence is very low at this point.
Thank you.
Thank you.
Well, I guess a lot of people are concerned about how long hormonal therapy should be given after primary surgery. So the patient has had either a mastectomy or lumpectomy and radiation. Let's say they either have or have not needed chemotherapy, but their tumor does require anti-hormonal therapy. So the standard has always been 5 years. And now many studies have been done either with tamoxifen, called the Atlas and the Atom trials in the UK, and for the aromatase inhibitors, and we have 3, letrozole, anastrozole, exemestane. And we've looked at 5 versus 10 years, either with tamoxifen, 5 versus 10 years of an aromatase inhibitor. And all the studies have shown the same sort of results. And there's about a 4% improvement by giving 10 years versus 5 years. But at what cost to the individual? There are side effects to anti-hormonal therapy. There are many women who tolerate it very well. I have women in my practice who've had high-risk tumors who at 10 years they've been tolerating their anti-hormone. They won't go off. They just say, I'm going to continue it. And we have others who are begging to go off at 5 years. So it's a lot of discussion, but more or less a rule of thumb is we take a look at the primary tumor. We see how aggressive it would have been. Did the patient have a lot of positive lymph nodes? Was the grade of the tumor particularly high? And other factors such as that. And for the most part, if the woman is tolerating the anti-hormone and they have a high-risk tumor, we would try to continue for 10 years. If they have a very low-risk tumor, small tumor, good grade, I have no problem at all taking them off at 5 years.
Thank you, Dr. Vogel. I want to ask Lesley Klein a question. She said she spends a lot of time debunking myths. Sugar. That's I had to ask. Sugar, and in particular with breast cancer, soy. A lot of questions on those two.
Two big questions. Okay, I'll do the soy first. All right. So some breast cancers are estrogen driven. So you may be diagnosed with an ER positive breast cancer, and that means that it's estrogen receptor positive. Soy is a weak plant estrogen. And so in theory, if your cancer is estrogen driven, why would you want to eat something that possibly could make it grow more? The component that's in soy, genistein, which is that estrogen piece, what we have found, humans don't metabolize it like other animals. And so it's really not an issue. The recommendation from the Academy of Nutrition and Dietetics, if you choose to include soy in your diet, which is a great plant-based protein, it should be non-GMO. It should be the whole soybean. You can have up to 2 servings a day. That means it's either 8 ounces of soy milk, a half a cup of edamame, or a third of a cup of tofu. And what we also know is that soy can be beneficial for osteoporosis and for heart disease. We don't want to take it away from you. We're not saying you have to start taking it, but if you would like to include it as part of a plant-based diet, there's nothing wrong with soy and breast cancer. Sugar. Sugar feeds cancer. That's what everybody tells me. Sugar actually feeds all cells, including cancer cells. But more importantly, sugar is a lot of empty calories, and those empty calories lead to obesity. And like I said earlier, there are 12 cancers that have been linked to obesity. Postmenopausal breast cancer is one of them. And so if you're looking at something like a piece of fruit, which has some natural sugar in there, fructose, that's going to be a lot different than eating a bag of Skittles. But either way, I still tell my patients not to eat the fruit by itself. Carbohydrates in general, because they're the preferred source of energy for your body, what happens is you eat it, your blood sugar shoots up, then you burn it off, and then your blood sugar drops, and then you're kind of dragging and cranky and hungry, and you start picking, and that can lead to overeating and more obesity. If you combine the carbohydrate with some protein, you're not going to get that quick spike in your blood sugar. It's going to be a harder combination to break down. So now it's going to be a more constant, even energy level. So for instance, if you wanted to snack in the afternoon, lunch was at noon, dinner's not till 7, around 3:30, you're thinking about a snack. If I just nibble on carrots because they're low calorie and I don't want to gain weight, it's kind of boring because they're a carbohydrate. They're not going to stay with me very long. I'm going to eat them, I'm going to burn them off, and I'm going to be looking for something else. But if I take those baby carrots and I dip them into some hummus, hummus is the garbanzo bean. That's a protein. And so that combination is going to be much more satisfying. It's going to give me a more extended energy level. It's going to stay with me longer and I won't be picking so much.
Perfect way to wrap things up. We've been here an hour having a great conversation, enjoyed your questions, some great answers. And I want to thank all the participants for coming here, those who came here to Sylvester Comprehensive Cancer Center at Deerfield, and those who are joining us on Facebook Live with Susan G. Komen, Florida. Thank you very much. And to our panel of experts for sharing their knowledge and such important information. And if you'd like more information, please go to sylvester.org. Thank you very much.